We welcome you all to Talk the Talk. My name is Janine Steen.
And I'm Tony Ann Antoniato,
the Masters of Myofunctional Therapy.
Together, we interview physicians, dentists, and other professionals to learn how their expertise can benefit you, your child, or your patient's speech and language skills and complement the services they are receiving. We welcome Dr. Michael DeLuke to this episode of Talk the Talk. Michael DeLuke is a board-certified orthodontist, educator, and coach who's passionate about helping doctors grow both in and out of the clinic. Dr. DeLuke has over 20 years of clinical experience and currently devotes much of his time to DeLuke Orthodontic Coaching, or DOC, a teacher, mentor, and to explore with his colleagues what it really means to thrive in orthodontics. Dr. DeLuke blends real-world experience with a holistic approach to health, mindset, and patient care, helping others find purpose, balance, and excellence in their profession. I am so excited and honored to have you join us today, and I can't wait to jump into this conversation together.
Well, thanks so much, Tony. I really appreciate you having me here, and I'm looking forward to it.
Yeah, definitely. So I always love to start with that, journey question. I understand that you are, your family is deeply rooted in, I believe, dentistry as a whole.
Mm-hmm.
So I'm sure that was something growing up, but, if you could share a little bit on your journey and how you first got into all of this.
Yeah, happy to. So I'm from upstate New York and grew up in that area and just outside of Albany. My grandfather was one of 7 children, Italian immigrants. They came in through Ellis Island, went upstate, and just had a drive to not be blue collar, to be white collar. And he had siblings that were all starting amazing businesses and landscaping. And he just felt this drive to just go get an education, which wasn't a thing back then. In the earlier 1900s, it wasn't common to see that in that population. So he ended up going to this Northern Italian, went down to Vanderbilt University. And he always would tell the story. And he was the first, they never had like Italian food. So he would cook for them. He was the first Italian fraternity member at Vanderbilt. And he would cook them food. It's something they never heard of. I mean, they'd never heard of any of the Italian food. So very different time, obviously. And so he had this drive to just become a dentist. And he became a dentist and went back to school. So he went to Columbia for dentistry, practiced a little bit, went back and became an oral surgeon. And then all 4 of his sons, my father being one of them, became dentists. One of my uncles is an oral surgeon. And then of the 3rd generation, I pursued dentistry and became the first orthodontist in the family. And then since then, 2 of my first cousins, so my one uncle's boys, one's now an oral surgery resident and one is an endodontist. So There is a pretty strong gene there for dentistry.
Your Thanksgiving table must be fun.
Yeah, true story. My uncle, who's the oral surgeon, quizzed me on the path of the facial nerve at Thanksgiving. No joke. When I was in dental school, he literally did. I'll never forget it. So, but part kidding, but he was also serious. Thankfully, I knew the answers. And he was involved in academia too, teaching at VCU. So we've just had a long family history, and all of my grandfather, my father and uncles have been in education as well as clinicians. And that I obviously followed a similar path in that I was a clinician. I started my own practice. I went to went to Stony Brook for dental school, right down the road from you, and went to UConn for ortho. And then started my own practice in upstate New York in the early 2000s, right out of my residency. Just started de novo practice and was fortunate to grow it into a very, very successful practice, and didn't want to go in with my family. I just felt that I needed my own identity. It was great to have them in my community and work on cases together, but I just felt I needed my own identity as my own practice. So I just literally started it up and ran that until a couple of years ago, I decided it was time for a transition into a little different path. And while I was practicing, my grandfather started a general practice residency up in that community at a hospital. And so I always taught there, and I ran the orthodontic part of that program. And I went back to UConn and taught in the ortho school. I was the cleft craniofacial orthodontist on a team in Albany. So I was really involved in education, but my primary focus that first 20-ish years was my practice and being a clinician. And then I really decided I put so much into that. I knew I wanted to spend the second half of my career more in the educational arena. So I made the decision a couple of years ago to phase down the clinical portion of my career and start really ramping up the educational portion. And that's when I launched Doc and the Doc podcast and teaching more involved in the teaching and educating arena. So yeah, it's kind of been the journey of my career.
Very cool. That's awesome. When you first stepped into your own private practice, were you right from the start treating on this more airway early intervention perspective, or was that something that happened later on for you?
Yeah, it's interesting you ask because I got no training in airway in dental school or in ortho. And I had really, really good schooling. I came out of Stony Brook. It's an amazing institution. And I came out really well prepared and even practiced general dentistry in my family's practice. I was moonlighting. We weren't really supposed to, but I was driving back from UConn. I would drive back to upstate New York 1 to 2 weekends a month and moonlight doing general dentistry on a Saturday in my family's practice. And that taught me a lot. That was huge. And I almost feel like more orthodontists should do that. A lot of the guests on my show who are in the orthodontic arena, who understand airway, had some amount of time in general practice, whether it was a general practice residency or they went out in practice and went back. And we can kind of circle back to why that might be in a little bit. But, UConn, we're trained to be really, really good tooth straighteners, like the best. People may know of Charlie Burstone. He was the founder of biomechanics, essentially. And I came out of there really knowing how to straighten teeth, but I didn't know how to look at the etiology of malocclusion. We were just taught this is what it is, right? You treat the patient, you treat the symptom. And I always had this predilection towards trying to find the why. I wanted to know, why are they like this? So in residency, and your listeners may not know this, but most orthodontic residents aren't treating young kids. So, and I've not only been involved as a resident, I've taught at multiple orthodontic residencies. I give lectures, guest lectures at many residencies throughout the country. And it's rare if you can find an orthodontic resident who's graduating from their program and has treated more than 3 or 4 kids under the age of 10, ever.
Wow.
And almost none under the age of 6, like literally. So that's one problem right there, is we're not doing this. And what's interesting is that's not just a challenge on the technique side. That's a challenge on the behavioral management side.
Yeah.
Because it's a totally different situation to treat a 5-year-old or 6-year-old or 7-year-old than it is to treat a 12-year-old. So we don't get the training, so we're not comfortable with it. So that's one challenge. So to my story, I started seeing when you go to practice, what happens. These kids are coming in earlier. And there's reasons why we don't treat them in the residency. Some of it is just they're not coming in. Some of it is a lot of the patients are on state funding. So they're on Medicaid. Well, Medicaid won't pay for interceptive ortho. That's more preventative. It will only pay if there's a craniofacial anomaly or a posterior crossbite or a significant, what they call handicapping malocclusion. So for your narrow, high vaulted palate, constricted arch form, moderate anterior crowding, no crossbite, poorly growing patient with potential speech malfunctional implications, maybe a tongue tie, those aren't on our radar. We look at those patients and we say, we got to send you to get teeth pulled because they're on state funded care. That's all they'll pay for is to pull teeth. So it's actually a system problem. So the orthodontists don't get to treat these cases. So we just get to be great screeners of kids that age and send them to get teeth pulled and say, we'll fix it when you're older. And that's a huge problem. But to my situation, I got into practice. And so all of a sudden now I come in and I'm kind of looking at these 6-year-olds and going, man, it's not their teeth. Like they're not, this isn't a big tooth problem. This isn't a macrodontia issue. This is a micrognathia issue. This is a small jaw problem. And so also there was kind of a pressure that I didn't sense in the residency where parents, when I would start to early in my career, be like, well, we might have to get some teeth out. And they're like, no. We don't want that. And I'm like, I'm not used to hearing that. Like, in the residency, the parents like, whatever you got to do.
Right.
So I just started thinking, well, there's got to be another way. And I was teaching at UConn, as I said, and I would drive back a couple times a month there. And it was well before the internet had a robust PubMed. So I would go to the library. And when I was at UConn and go early or at the end of the day. And I just started trying to read more about early treatment and early expansion and expansion in the mandibular arch, which was and still is most places a huge no-no in the orthodontic profession. And we can certainly talk about that. So I started researching it and I'm like, wait a minute, Schwartz and Gratzinger were doing this in the 60s. Ricketts was doing this in the 70s. This is not new. McNamara was talking about this in the 80s. Why did I learn that you never expand the mandibular arch? Like, what is going on here? And so in my patients, I literally just tried it. And I told the parents, we still may need to take teeth out, but if this works, we won't. So no comprehension of airway. Like I wasn't thinking airway. I wasn't thinking breathing. I wasn't looking at nothing. I literally was just trying to treat the etiology of the small jaws and avoid having to extract teeth. So that started me on this quest in the early 2000s.
Okay. And I assume that as you started to grow those jaws, you started to see it, the airway side of things with your own eyes, your own patient.
Yeah. Well, a little bit embarrassed to say it, not right away. It took a little bit of time to figure it out. Again, we're hardwired to be very literal in our analysis and our diagnosis. We're trained off of Ceph numbers and growth indicators, and we just aren't looking at the why. We really aren't. So did parents start saying to me, geez, Dr. Mike, you think it's a coincidence that Johnny doesn't snore as much anymore since you started doing this? And I'm embarrassed to say, I was like, well, it can't hurt, but like, I don't know that I'm having any direct impact on that. And it wasn't until probably 4 or 5 years in, sadly, that I started. Now I was still doing great things with phase 1, and we weren't having to extract teeth, and I was doing upper and lower expansion, and it was working beautifully. But I didn't realize the impact I was having on airway. And then probably maybe 5 years into practice, it really started to hit home. There's something else going on here in these younger patients. I'm just seeing them look better, breathe, but grow better after. And that was one thing that really tipped me off is the patients I treated with phase 1 like that, they didn't grow as like vertical growers, right? They didn't have as much severe retrognathia. They just grew better. And I'm looking at this going, this is something for sure. The problem is when you do, and this is another challenge for orthodontists, when you start doing a lot of phase 1, it bogs down your practice.
Okay.
We make our money straightening teeth. It is what it is. And we run these hyper efficient practices. They're very systematized. They're very time-based. We are taught from consultants, don't spend time in the consultation room. You make your money in the clinic. We're not trained in our practices to be diagnosticians. We're trained to be clinicians, and we live in that world. So all of a sudden, my practice is getting really busy, and this phase 1's just bogging me down. And I was using upper and lower expanders and then brackets on the incisors, and I'm like, there's more emergencies. And this was before digital printing, and everything was with alginate impressions and pickup impressions. So it was very time and labor intensive on my team, and it was bogging me down. And so I got a taste of why a lot of my orthodontic colleagues didn't do it. And most of us undercharge for phase 1 because we're taught charge like $3,000, $3,500 for an upper expander. And everyone's seen those patients and knows those patients where went to the orthodontist. The orthodontist only put an upper expander in with or without a crossbite, said, maybe we can get a little more room for the teeth. Didn't do anything on the lower, didn't do anything with myo, didn't do any of the growth modification. And it turns out it doesn't really help or make a difference. And then people say, well, phase 1 doesn't work. And I think because of that, a lot of orthodontists don't charge a lot because they're thinking it's probably not good. I don't know if it's going to really work anyway. So you're not charging a lot. It's costing your practice a lot of money to make these expanders and deliver in the visits and the time and the emergencies and all of that. And so it's a bit of a deterrent to most orthodontists to do this. Like, why not I'll fix this when they're a teenager and I can charge them, $7,000, $8,000 and straighten their teeth. Like, you know what I'm saying? Like I'm not knocking those orthodontists for that. I get it. It's an easier way to run a business.
Right.
And so I started figuring out I can't keep it was burning my staff out. Like, it was getting really, really challenging. Wow. So I developed a way in about 6 years into practice to do this without expanders. So I started doing it just with braces and wires. And if you start these kids young, it works. And I teach this all around the world now, how to do that. And I started very cautiously, and it was on some children who had special needs, and the parents were begging me not to send them to get teeth pulled. And so again, not really airway aware yet, kind of thinking there might be something here, but not even really tongue aware, not even understanding what the tongue is doing. I'm just trying to not have to extract teeth on these patients and to get them to have normal size arches. And then I started doing this, and it was just a game changer. The expanders aren't in the way of the tongue. You don't have the speech issues. You don't have the articulation issues that go along with that, and the embarrassment and the salivating and the ulcerations on the dorsum of the tongue and roof of the mouth getting irritated. So that became the way I started to do it. And about that time, we're now maybe 8 years into practice, I got a CBCT. Actually, no, it was about 9-10 years into practice. Yeah, because it was 2014. I got a CBCT. It was a low-dose CBCT. And it was when they first come out. And that's when the light bulb started to go off that, wait a minute, what I'm doing is changing the way these kids are breathing. This isn't just about making room for teeth. Like, I'm looking at before and after images side by side of their cone beams. And I'm like, whoa, this isn't, where'd the adenoids go? Where their tongue, the shape of the palate, when you can look at it in those coronal slices in the CBCT, the intermolar width, all of these indicators, the intercanine width, which is a big part of braces and wires, because when you I'm sure you've seen it, they take expanders on these narrow V-shaped arches, they expand and they get really wide posteriorly, but in the anterior and middle thirds of the arch, they're still somewhat narrow. Yeah. And the tongue doesn't have room, and that palate's still high and vaulted up in the premaxillary area. That goes away with braces and wires. Wow. Because with braces and wires, I can expand, if I want, let's say 3 millimeters across the molars, if that's all they need, and 10 across the canines. Because if I have a wire, I can build it to whatever shape I want. And some people in your audience might astutely say, yeah, but Mike, you're just tipping teeth. I have the pre and post cone beams to show otherwise. But if you look at the literature is full of examples in the 70s and 80s of radiographic evidence of people who were doing light expansion. At that point, they were using like a quad helix or a W arch, 300 to 400 grams, is less than a pound. And, each time you turn an RPE, it's about 3 pounds of force, 3 to 10 pounds of force, really, is what the study said. Whereas this is less than a pound. So it's light, it's continuous. That is enough to get orthopedic change, not just dental alveolar, not just dental tipping, but orthopedic change in the maxilla. And there are radiographic studies to show this. In a study in 1975 by Bert Melson and AJO, highlights why. It's a histological evaluation of the anatomy of the midpalatal suture. And it shows what they call the infantile suture. It's wide open. Wow. There's no interdigitation. There's no ossification. It is like a wide open, straight shot highway. So when you put very light forces, you stimulate that alveolar bone on an orthopedic level up in the palate to start to grow. So you don't get this big separation with this huge diastema. It's gradual. It's physiologic. There's not as much trauma involved. So I'm starting to put all these pieces together. And then I start to realize, into your arena too, like the tongue is doing a lot of this work. Because I would put to start an 014 nickel titanium wire, which is a really, really light wire. You may be going to deliver like 150 grams of force. They would come back in 8 weeks. And I'm like, they're already significantly expanding. Wow. And I started to realize, oh my gosh, the tongue is starting to have a home. It is getting up into the palate, and it is shaping the palatal vault and allowing the palatal shelves to start to assume a more normal architecture. And again, I'm literally just, if I can give anybody advice, whether it's in the myo arena, the dental arena, medical arena, look at your cases before and after, always. Wow. Your failures, your successes. I figured all this out just by literally looking at before and afters and looking like, wow, this kid just like looks healthier. Their eyes look better. I didn't know anything about allergic shiners at this point. I didn't know about any of that. I didn't know about allergic rhinitis and the impact of, there was an article that just came out in September of 2025 about rhinitis facies, kind of like an adenoid facies, but the rhinitis side. I had no idea of any of this. I'm just looking subjectively saying something's different with this kid. Wait, their head posture is like totally different. In the beginning, they were kind of slouched and the chin was up. Now they're upright and they look really balanced. So that came out of being really critical of my own work. And that just kept me down this path. And then I started to really understand it. And then I would educate parents and start asking sleep questions. And that just went on from there. So again, it took me a good, embarrassed to say, about 10 years from the time I started with an early treatment mindset to the time I really realized that this had implications in airway.
Right. It was more than you even knew what it was at that point. You were doing it for other reasons, yet you were growing airways and helping children be healthy. I mean, ultimately, right? Whole body health based on growing that airway and sleep. And I'm sure, just like many say, once you see it, you can't unsee it, right?
Completely.
Wow. That's amazing that you kind of really taught it yourself. I feel like a lot of orthodontists currently, they have mentors like you and organizations to go to and conferences to go to learn about this. But your journey, you kind of did it solo and just taking some research that was already out there and figuring it out for yourself.
Yeah. And I mean, there wasn't, going back then, we didn't really have resources that we have now.
Right.
There weren't podcasts. You couldn't just hop online and look this sort of stuff up.
Right.
You didn't even have really meetings that talked about airway, and there was just no real resource for us there. So that's why it's so important for everybody to take the time to look at their work and look at their cases critically before and after. Spend the time in diagnostics for the orthodontic and dental arena. Don't just look at the malocclusion and think, this is what it is. I can't do anything about this. They're not going to outgrow it. Right. No, I don't think anybody's ever. McNamara has a great article about this. If you're once a class 2, always a class 2. I mean, you're rarely ever going to outgrow a class 2 without some sort of intervention, without some sort of assistance. So, looking at your patients more critically and asking a more detailed history, asking sleep and behavioral questions. I literally just stumbled upon it because when I was seeing it, I started going into my consults, and I would say to parents, when I would now see the signs in the pre-treatment CBCT and on the pictures of the face and the chapped lips and the chapped gums that I call them with the hyperplastic irritated erythematous anterior gingiva, I started asking sleep questions. Tell me about how they sleep. Do they snore? They have allergies? Are they congested chronically? And that's how it started. The PSQ was out in 2000. I'd never even heard of it. I didn't know what it was. I was asking a lot of PSQ related questions, but I didn't know what I was doing really. I was just feeling it out and sensing it. And then more and more and more parents were just saying, how did you know that? Like, you're the orthodontist. Why are you the first one to ask me about that? And yes, they're a terrible snorer. And I've been telling the pediatrician for years, and they're just like, they'll outgrow it. And so that started me down that path to realize that not only was I doing something, but I had to become an advocate for these kids to be able to help other people see it like I saw it. Yeah.
Yeah. And I feel like, and tell me if you agree, I feel like with the parents, it's almost like you don't have to really convince them much, right? Like it starts to make so much sense to them so quickly where they're like, yeah, their mouth is always open and they wake up all the time, or he's still bedwetting, or I hear him grinding his teeth from the other room. It's like, it just clicks for parents, I feel like, because they get it and they're so invested in their child and they want obviously the best for them, but there's not a lot of like convincing there.
I agree. And the parents there's kind of two parts. I find there's some parents who are, like you said, and they're just relieved that I knew it. Like I knew I wasn't crazy. I used to hear that all the time from especially moms. I knew I wasn't crazy. I knew something was wrong. And you're telling me this could be related to why he's not doing well in school? Yeah, it could. And they're like, I knew it. They were talking about ADHD, and I don't think he has ADHD. And they were talking about medications. I mean, you would hear it again and again and again. There's the other group of parents, especially I feel the dads, and as a dad, I can say this, they tend to be a little more resistant, right? The type, they're kind of like, oh, I don't think anything's wrong with my child and this is fine. And the pediatrician said they'll outgrow it. And what does the orthodontist know? So I came up against a fair amount of that as well. And I would just be able to have that conversation of educating them. And that's where the cone beam, the CBCT became invaluable because I could show the more literal dad mind of like, hey, look, dad, we're going to go on a little tour of Johnny's airway. And anywhere I go with this little crosshair, when I go into his nose, anywhere there's black, air can go. And anywhere there's gray or white, it can't. And when you do that and you start to take them up through that path, and you have the 3 different slices there of the sagittal, the axial, and the coronal, and you can look at it in those 3 planes of space, multidimensionally, dad sometimes will be like, wait, there's no black there. Yeah, that's because Johnny's turbinates, they're called, their fancy name for these things that help filter and moisture and purify the air. His are really swollen and air can't get through there, which is why he's got to open his mouth to breathe. And so I know I'm not the allergist or the ENT that's going to fix that, but I am able to detect that because as an orthodontist, I can look at that entire area and understand the anatomy. So then if you breathe through your mouth, that's why Johnny is growing really narrow and with really crowded teeth. So it's not just about giving Johnny straight teeth at 6 or 7, because that's an obstacle. We have to reframe how we talk about this in the orthodontic arena, because when you go to tell most parents, I just had on an episode of my show recently, an interview that I'd done a couple of years ago with a family I treated in the practice, and the daughter came in at 6, and the patient had one protrusive incisor, and mom said that the pediatric dentist told her, yeah, you don't need to go to the orthodontist yet. She'll need ortho one day, but you don't need to go. Mom was just worried about trauma to the upper left central. That was it. I then start talking to mom about airway and breathing and detect all these other things. Well, come to find out, the patient was suffocating every night, had been to the ENT. Dad was a certified registered nurse anesthetist, so he understood airway, and he was going in at night. They were taking shifts, propping their daughter's head up so she wouldn't suffocate. And when I started asking these questions, and mom tells this story on the podcast, she's like, I was like, why are you asking me this? And how did you know this? By looking at these sort of dental orthodontic images. And so I caught it, but mom talks about the fact that she still was thinking, even with that, like, what do her teeth have to do with this? And how is an orthodontist going to do anything with the way she breathes? So there is that obstacle to that. And we have to reframe it to say, we're more than just tooth straighteners. Right. We're treating the entire patient, and we have a responsibility to look into this, because the parents aren't all accepting of this either. Truthfully, I agree with you. The ones who want and it's getting better. It's getting much better. Social media and podcasts such as yours and resources, people and mine. People consume more information, so they're more aware of it with AI and even just a Google search now, you can find out a lot. But I'm going back, 10, 15 years ago, there's a lot of opposition from my colleagues, from the parents. And I think in an interesting way, Tony, and that made me stronger and hone my skills because I had to be really, really good at explaining it and educating because people weren't just believing it. They weren't coming in saying, my child has an airway issue. I saw something online about this. Like never. Okay. It was not. That never was happening to me. Yeah. I had a lot of explaining to do when I detected these issues for people who were already thinking, why am I in the orthodontist office with my child at 6 years old? Right? Like that's too young. I got braces at 12. They're too young. Right. And then on top of that, now we're going to talk about that they're not breathing well. And gets back to the original point. That's a big obstacle for a lot of orthodontists. It really is. And I get it. Like that changes the way you practice, and not everybody wants to change that.
Right. Yeah.
I wish they would, but it's just the way it is.
Yeah. Where do you think, that change needs to happen? Do you feel like it's in the academic, the education of things? And at that point too, should all orthodontists know how to treat younger, or do you feel it should be like a specialization, that it really needs to be that not every orthodontist can put enough effort into that age?
Yeah, great question. So I'll start with the first one of the education system, and then we'll kind of come to the age ranges. Okay. Educational system needs total transformation, total overhaul. It's not good. There are some outliers out there. Actually, in your neck of the woods, Dr. Miraj Ahmed at Montefiore, I work remotely with their residents, and I'll be up there speaking to them in May. They get it. He's amazing. He is doing wonderful things, helping those residents understand everything we're talking about. Sadly, that is the exception. The majority of orthodontic programs are run by very traditional, old school minded orthodontists who lived and worked in and taught in a reactive tooth straightening world. And our boards still require an extraction case. The system is really broken. And the AAO, and I've been openly critical of them on this, they don't seem to yet want to do anything about this. They are run by the same people running academia. And that establishment of orthodontics is very resistant. They won't, I've applied a couple times to speak at their meetings, and I get told that the scientific committee, which is comprised of, I believe, only 5 people who are very traditionally minded, told me that my topic was pediatric sleep disordered breathing and why we need to be aware of it as orthodontists. And I've been told every time I've applied that my topic is neither interesting nor relevant. And they are afraid that I am going, literally, they said they are afraid that I am going to promote indiscriminate expansion.
Wow.
Which is orthodontic code word for expansion in the absence of crossbite.
Wow.
So, they're right. I would be promoting that. And many directors of orthodontic programs tell their residents that expansion in the absence of crossbite is malpractice.
Wow. That's still happening.
Oh, that's the norm. That's the norm.
Wow.
That's the norm. So I've been told by orthodontists that I taught with that I should have my ABO certification taken away for the way I practice, that I should have my license taken away. It's big. And so the thing is orthodontists in the community, a lot of them are hesitant. I ran my own practice. I didn't have to answer to anybody. Right. So you have to realize that challenge too. If you're a young doc, you may be somewhat interested in this, but what if you go practice in a corporate? You're not changing the way they do it.
Right.
You're not making them buy a CBCT. What if you practice for a group where you're low man or low woman on the totem pole of 4 docs, or even just the junior partner of 2 docs? You can't walk into a practice and change the entire way that they practice if that senior doc or docs is or are not open to it.
Right.
There's a lot of obstacles. So I know everyone is really hard on the orthodontists, and trust me, I am too, and I will continue to push the orthodontic profession. That being said, there are a lot of reasons why the orthodontist out there practicing is resistant to this. And we've highlighted just a few of them, but probably the most significant is they're not taught it.
Right.
In fact, they're taught it is not a thing. So we have a lot of work to do to change academia. And that's one of my bigger goals that I continue to work on. As far as the age groups, it ties together quite a bit with the academia, as I said before, because we're not treating young kids. We're next door oftentimes to the pediatric residents, pediatric dental residents, yet we don't talk.
Oh my gosh.
Right. I mean, they could be screening these patients young. We could be doing growth guidance together. There's no communication. It's so siloed, even within these institutions. And so orthodontists don't know, by and large, how to treat young kids. I happen to be very blessed that a lot of people listening to the show on Long Island know Fred Ferguson, Dr. Ferguson at Stony Brook is amazing. And he was there when I was there in the 90s. And I learned patient management skills from him. He taught all of us, especially in the patients with disabilities clinic, how to handle and manage very, very challenging patients. And I really credit him with giving me the confidence to start treating some of these younger kiddos, because it's totally different. Like, you can't just be like, okay, Johnny, you're gonna get your braces on today. And Johnny's just more concerned, Johnny's 13 and there's a girl in his class, like, the 2 seats over. He just doesn't want to look like, embarrassed in front of her. So he's gonna let you do whatever. He's gonna just not. When they're 6, they're like, what's this? What's that? How's this? Why is that? Why are you doing this? And if you don't know, and then on top of that, you have to train your team how to deal with these patients. So it's a lot of work. It's a lot of time. Now, once you get it down, it's not hard, and it's awesome. And I love those littles like that. They're so much fun. And even younger. I mean, they're just, once you understand how to speak their language and get them to understand what's going on, it's really, really fun. But not every orthodontist wants to do that. So I do see the potential for the profession splitting into almost 2 different factions in the future, where we have orthodontists, what I call, and I spoke about a little at Panny, the Ortho 2.0 versus 3.0.
Yeah.
If you've read Outlive by Peter Attia, he talks about medicine 1.0 being like Hippocrates and bloodletting and all that. So, orthodontics 1.0 analogous would be way, way back in the beginning. I mean, there are studies, or there are reports that like France, Pierre Fouchard was doing this in like the 1500s, but most part, they credit like 1800s into the 1900s, were mid to late 1800s when the first kind of concepts of moving teeth and doing this was established. And then through the 1900s, traditional style orthodontics. Although, interestingly, there's a lot of articles from the early 1900s that talk about airway and the need to be focused on mouth breathing and how we breathe, but the profession still became very mechanical. And he talks about medicine 2.0 being this Western medicine, right? Reactive, treat the symptoms. Don't be proactive about it, but let everybody get sick and then try to fix it. And so I look at orthodontics when I was reading the book, I'm like, well, orthodontics is the same way. Like the traditional orthodontic model is let everybody get crooked teeth and then try to straighten them. Let everybody grow poorly and then try to like redirect things when they're older. And I said, he calls for medicine 3.0 to be a proactive, whole patient, holistic, centered, multidisciplinary approach where we're trying to not just give good outcomes on that procedure, but to give a better health span or quality of life for these patients. And I said, we need Ortho 3.0. We need a proactive, patient-centered, holistic approach to patient care that looks at the overall health and well-being of this patient, not just straight teeth. And honestly, I really believe that mindset shift that's the paradigm shift we need. It's because you're not going to convince a tooth straightener 2.0 orthodontist that they should start treating kids earlier.
Mm-hmm.
You're not. Just like you're not going to teach a physician who is really immersed in sort of the traditional Western medicine of treatment of issues, right? To revamp their entire practice and become more functional, along the lines of functional medicine or holistic or proactive and preventative. You're just not, for the most part. What you can do is you can help people see there are different ways you can choose to do this.
Right.
Because there's always going to need people in the medical world who need the reactive treatment. You're never going to get everybody proactively. There's always going to be people in the orthodontic world that need their teeth straightened because they never did anything younger, right? Or have an airway problem. They don't realize it till they're older. So that's going to be one group of orthodontists, kind of the traditional tooth straighteners. And I think you're going to have another type of orthodontist that's going to focus on younger, proactive, patient-centered treatment, working with speech and language pathologists, oral myofunctional therapists, their ENT colleagues, their allergy colleagues, working with their other dental colleagues for releases, going in and start, craniosacral therapy, all the different adjunctive modalities that we can start to incorporate into patient health from a young age to start to help guide and direct the growth and development of these kids proactively. So I know it's a long answer to your question, but the point being is, I really think it's going to split into two camps, because I just don't see many orthodontists who want to be seeing a 3 or 4 year old and then go see a 55-year-old and then a 12-year-old. It's hard. Like I did it. I made it quite as young as 3 or 4, but 5, 6 in my practice was about as young as we were going at that time. But even that was young for an orthodontist at that point. And it's hard. I mean, literally there were times I'd have someone 85 in the chair and someone 5 next to them. And you've got to train your team to be able to handle both of those patients.
Right.
The 85-year-old, you can't tip back too far for blood pressure reasons or comfort reasons. The 5-year-old is standing on his head. Like, it's not easy to do that. So I think we're going to probably see some subspecialization within the orthodontic arena. Now, whether that'll be recognized by like the AAO,
right?
I don't know. Whether there'll be other institutions developed to train them, I don't know. But I do think that you're seeing this split happen in our profession right now.
Yeah, definitely. I see it, locally, where I know the orthodontist I have to refer to if I am meeting with a child that is 6 or in mixed dentition, or, mom said, well, the dentist said they haven't lost enough teeth yet to go to the orthodontist. So it's everywhere, but I know that I have some really great orthodontists that I would be really comfortable sending my 12-year-old patient to, but wouldn't be the same orthodontist I would recommend for the 6-year-old sitting in front of me. Yeah,
then that's such a great point, because they are a different skill set as well. If you really like straightening teeth, I guess I was kind of unique in that I love straightening teeth, and I took a lot of pride in getting really, really good orthodontic results. And I don't think people with that tendency maybe are as likely to get as much into the early treatment too, because you get really, really busy. If you're a good tooth straightener, you get really busy straightening teeth. So you don't have the incentive to start to do it differently because you're so busy just doing that. And again, I don't think I would have been down there done that path if it weren't for the fact I started my own practice with no patients. So when I started, I just would look at a patient. I had the time to figure out, well, what do I want to do to try to help this patient? And I made mistakes. I put a lot of patients on observation that I didn't detect all these other issues. I was like, well, they're a little crowded, they're a little narrow, but we can fix this when they're older, because I had no idea about airway. I had no idea about tongue function. I mean, I had no idea. So I was like, and then I look back and I missed it. I didn't know. And so again, I had the ability to learn that. But if you just jump in, you got to remember too, a lot of these young docs, they come out, they go from treating 10, maybe patients a day in their residency on a busy day to all of a sudden being expected to see 75.
Wow.
In a day.
Wow.
And their heads are spinning.
Yeah. Yeah.
And so they're just trying to figure out how to do this. And so now we're going to all of a sudden tell that doc, oh yeah, we also got to start to see young kids, which you know nothing about, how to treat the young kids. And I had a very fortunate set of circumstances looking back that my practice just evolved the way it did, that I ended up being able to have those experiences on all the different sides of orthodontics. But that became separate notes. And the podcast episode I just released recently, an orthodontist and I talk about this. She's a similar age to me. That becomes draining. The burnout of trying to treat everyone from 5 to 85 is real.
Yeah.
And train and hire staff that can handle all those different types of patients and personalities and treatment modalities. It's hard to do that. And then it's hard to find associate docs because you're recruiting a doc to your practice. And that was a huge problem for me. They saw how young a lot of these kids I was treating were. And they were like, I don't feel comfortable treating these young kids. This isn't what I'm trained to do. So there's a lot of obstacles that are, pretty legitimate. And I know it's easy to finger point from people on the outside to say these darn orthodontists. And I get that. And I do that myself. I get frustrated with my colleagues. At the same time, I just ask people to have a little bit of grace to say, but maybe there's actually reasons. I really don't believe that any orthodontist goes into this looking to do harm to their patients. Right. I just don't. I mean, we go to school for way too long and put way too much time and money into this to like have ulterior motives, so to speak, of not helping patients. I think we're all altruistic in this. They just don't know better. And there's no incentive. It's actually a disincentive in a lot of ways for them to do anything differently. So we're all victims of habit, right? We're all victims of what we're comfortable with. So,
Right. Yeah. I mean, if they're not hearing it in their schooling and they're not seeing it in their residency, how are they supposed to know? And then they think, well, I could treat it at 9 when they're going to just sit in the chair and let me do what I got to do. Why would I try to do it with a 4-year-old who's all over the place?
Yeah. And I think that's where you get a lot of the ego of the, well, I'm an orthodontist or I'm a board certified orthodontist, who is this general dentist or this pediatric dentist or this myofunctional therapist to tell me how to do orthodontics. And I just encourage my orthodontic colleagues to just set that ego aside for a second. It's not that they're telling you how to do orthodontics. I don't think I've ever heard anybody with whom I've spoken say, I could do orthodontics better than the orthodontist. I really don't. To the opposite. Most are saying, I don't want to do the orthodontics. You guys do amazing, crazy things moving teeth that I'm just not trained to do and don't want to do. They're just asking us to open our minds to doing things more proactively and earlier. That's it. And so, I think we just all need to take a breath and say they're not threatening us to try to take over our profession. I do think if the orthodontists don't wake up, I think we're going to have a major problem on our hands as a profession. I really do, because more and more pediatric dentists and general dentists are getting this and they're pushing us. And if we're not open to it, they're doing it. They're doing it themselves.
Yeah. It's, always interesting to me because in school for speech pathology, early intervention is hammered into us from the start. Everything. It's, early intervention. That's how we're going to get these issues to be resolved and be able to get through it as quick as possible. Treating it earlier, they'll get through it faster. So it's always such common knowledge in the speech side of things of like, of course, we're going to treat it as soon as we see the signs. Like that's when we treat it because we're going to be able to remediate it faster. So it always made sense on the ortho side, but realizing that that's not how it's taught and that's not how a lot of orthodontists see it.
Yeah. And it's fascinating to hear you say that. My wife is an occupational therapist, retired now, but same thing. She focused on EI, on early intervention and birth to 3. And when one of the states we lived in, I think Connecticut, one was birth to 3, one was early intervention between New York and Connecticut. But so that concept was, again, it didn't hit me till you just said that, but that was integral to her training. So the dental profession and by and large, the orthodontic profession has really become a reactive profession. And I guess really the medical profession too. That's Peter Attia's point. The analogy for the audience, if they haven't read the book that he talks about, is he was so busy trying to, as a clinician, running around trying to catch the eggs. It was the analogy he used that are being thrown off the roof. He's running like crazy to prevent the eggs from dropping when he was a traditional sort of medicine 2.0 guy, that he realized, why don't I go figure out who's throwing these eggs and get them to stop? And that's the mindset shift we need as orthodontists. Like we are so busy straightening these teeth, chasing these eggs that are falling all day long. We need to at some point stop and say, maybe I could make it so there's not as many eggs falling here. And I really feel that's that, again, the 2.0, 3.0 shift that we need.
Yeah. What about in terms of the parents, listening here, the audience of the parents? What would you say to them? What would you advise them on when to first have an orthodontic consultation? What could be signs that could mean your child could benefit from an orthodontic consultation at 5, at 6, and not waiting until the the dentist says they need to lose more teeth? What would you say to those people?
Yeah, so it's an interesting question. What would you say the orthodontic community says is the age? Just out of curiosity.
Around here, we usually hear 7.
Okay, that's what I was guessing it would be. The reason for that is the American Association of Orthodontists. It has on their website a part that says the importance of early checkups, and they say how the AO recommends children complete their first checkup with an orthodontist by age 7. So that's where a lot of that age 7 comes from. Now, it's important to note it doesn't say at age 7 or at or later than age 7. It says by age 7. And the website also says that if your child's younger than age 7 and you notice something, and I think their wording is like it appears off, like they're kind of put in lay terms, you don't need to wait until your child turns 7 to see an orthodontist. You should take your child to the orthodontist if you notice one of these issues. And if you look at what they say for issues, one of the issues is mouth breathing.
Wow.
They list out like 6 issues. It's one's mouth breathing. And they talk about on the AO website, they talk about the fact that many orthodontic problems can result from a child mouth breathing. And that if you're concerned, take your child to the orthodontist.
Right.
And another issue they cite is facial imbalance. Another one's difficulty chewing and biting. So when you ask what age, it's really confusing for providers, for parents.
Yeah.
Because everyone gets this like age 7. That's kind of an age of convenience. There's no real data. There are no randomized controlled trials that tell you what age to start orthodontic treatment. That doesn't exist. People say it's not customary to start younger. Well, that's false. If you, not in the past, maybe 20 years, but if you go back before that, we were starting patients. There was, as I said, back to articles I can quote from in Laryngoscope and in JAMA in the early 1900s, talking about you should wait no later than 30 months to begin orthodontic treatment. The medical community asking us to intervene early because of the damages that can happen from mouth breathing over 100 years ago.
Wow.
So it's not fringe. It's not this new airway phenomenon. We've known about it for a long time. It just, I believe insurance drove a lot of this because what happened was insurance doesn't cover a lot of ortho treatment. If you a benefit, and oftentimes that's maybe $1,000, $2,000. And you hear the orthodontists all the time say, well, I don't want to burn their whole ortho benefit in phase 1 and then not be able to get phase 2. So I'll just wait and do it all in one comprehensive phase later. I think it's a huge additional part of it. We've talked about a lot of obstacles. You might not be depressing about all this, but you can see how many obstacles there are. There are a lot. And so that's another big challenge. It's just a number of convenience. The AO president recently at a meeting was commenting, I didn't hear it firsthand, but secondhand from someone I know who he said to, like, there's a problem is they lose their benefit and then they can't afford a second phase later. And he wasn't saying it in a hostile or derogatory way. He was just being practical. Like, this is a problem. Like, they don't, and we're like, yeah, the person was telling me, we're like, yeah, like, can't we do something about this to get them advocate for benefits earlier? And I think maybe that's going to have to be something we get into the medical arena with. It's a big, big project, but maybe we could start to get medical coverage for more medically based, proactive early treatment. That's not like dental tooth-based.
Right.
And then save the ortho benefit for later. Certainly we can save a lot of money and time in anything from the special education these kids might need to cardiovascular defects to when they get to be adults and have OSA. And I mean, just, the amount of medication and time and energy that's put in this in the medical system is, I don't know. I mean, it's exponential.
Right.
So I think that's something we could try to all advocate for is coverage earlier from a medical perspective, that this is proactive treatment to help get this child breathing the right way.
Absolutely.
And then the orthodontic benefit can be separate. Sadly, the AAO lobbied to the ADA Insurance Council 2021, maybe ish, to cut the majority of the phase 1 codes.
Wow.
So we lost the majority of codes that we used to bill for phase 1, which is just a further deterrent to anybody doing anything in phase 1.
Yeah. So
that's a real problem. But again, the AAO, I think, has just made that number 7 because we're not comfortable treating these patients before they have adult teeth. We're just not. Even the behavioral management side aside.
Yeah.
It's like we just are taught like crooked baby teeth aren't a big deal. But they are. I mean, E.A. Bogue knew that in the early 1900s when he was talking about the fact that you need certain, spaces between the bogue spaces, between the primary teeth. You need room. They should be growing in a certain pattern with certain palatal vault and certain widths. Bogue had widths between the teeth that he was trying to quantify over 100 years ago. So I just think it's become a number of convenience. So for the parents, AAO says as soon as you see something looks off, which means if your child is sleeping or breathing with an open mouth, if they're have an open bite when they bite down and you can see their tongue, if they have a tongue thrust, if they have weak oral motor tone, and it's more certainly your area than mine, but if they're having trouble chewing, if your child is snoring, period, hard stop. Children should not snore chronically. If they're sick or have a cold, that's one thing, but they shouldn't have chronic snoring. I've had many sleep physicians on my show and they all say that very thing. So if a parent sees these signs in their child, bruxing, you alluded to that earlier, if they're grinding their teeth, clenching, especially on the anterior, when they bring that lower jaw forward, that's them that's that sympathetic overdrive, and pulling that lower jaw forward away from the airway to pull the tongue forward to let these children breathe at night. Any of those signs are reasons to take them in. Now, a lot of people listening are probably thinking is, yeah, but what I called the orthodontist and I said my child was 4 and they were like, we don't see 4-year-olds.
Right. Yeah, absolutely.
And that's a problem. I hear it all the time. I hear it all the time. And that's gets back to what we said before with the education. But that is real because there's, and that's why a lot of the pediatric dentists and general dentists are starting to do more of this early treatment.
Yeah. And that's where, from my perspective as the speech and myofunctional therapist, I have to figure out those providers. I have to create, that community so that I could say hey, I know you love your orthodontist that maybe treated your older child, but he might not be wanting to treat your younger child. Your child's only 4. I'm going to give you some names. These are orthodontists that I know have this. I kind of say it in a way that it's like a specialization. They specialize in early intervention orthodontics because it's, hard, especially when they did so beautiful on my older son or my older daughter. I'll bring them there. And I'm like, well, you might not hear exactly what I'm saying from that orthodontist, but, just like in other things as speech pathologists, we don't learn, about myofunctional therapy in graduate school. We don't learn about tongue ties or anything, related to that side of things in grad school. So even in our own community, it's like, oh, he had speech, he was in speech for 5 years and he still is a picky eater or he still can't say his R sounds. And we have to kind of differentiate there. Speech therapy can look different by the person who's doing it or the type of approach that they have. Not every speech therapist is trained in orofacial myofunctional disorders, and spend that time to educate on why treatment here will look different than probably the treatment that your child received in the school setting where it's more academic based. And again, no wrong to those SLPs. They, you practice based on the setting that you're in and what you want to specialize in. But we see that divide somewhat within our area of speech pathology as well.
That's interesting. Yeah, it really is. And then the parents have to understand something that is so foreign to them, which is what is a 4-year-old doing in an orthodontist's office? Right? And let's be real. They're thinking, what, they're going to charge me 3 times now for treatment?
Right.
How many times are they going to need it? And that's hard too, because one thing that kind of a pet peeve of mine is when anybody doing this says, well, when we do something at 4, they're not going to need orthodontics later. I mean, we really have to be careful with that. Will it most likely and almost certainly decrease the severity? Yes. But you don't know if they're going to end up with an impacted second molar or an ectopically erupting canine. There's so much more that can happen. So, and I've done this, so I can say really confidently that when you do, especially the braces and wires, when I used expanders, I didn't see it as often. When I did the braces and wires and really developed these beautiful arch forms in these young 6, 7, 8-year-old kids, they didn't need, most of them did not need a lot of phase 2. I mean, very little, if any. A good number of patients didn't need anything, but some did. Some still grew poorly with their lower jaw, and we needed some sort of growth modification of the mandible later. And so I just caution people, and to the parents as well, if you go somewhere and they're like, oh my gosh, we're going to do this now, and they're never going to need to see the orthodontist. we have to be very careful with that.
Right.
It's what we know, which is getting them to be nasal breathers and grow in as ideal a function as possible is only going to help them out. And is almost certainly going to decrease the amount and complexity of orthodontic work they need later, especially the chance that we'll need to pull adult teeth.
Right.
I'm even comfortable with that. It'll really decrease the chances, but to eliminate treatment. And actually, can I mention something on the extraction side?
Yeah, please.
So you've probably heard the debate over whether extractions cause airway problems.
Yeah.
So I have an interesting take on that as well.
Okay.
And there was a study that came out in 2015 by Larson et al. And it was a very, very poorly done study, And it didn't look at, I won't go into the details of the study now because it's kind of a complicated conversation, but basically it concluded that extraction of teeth does not lead to an airway problem. Okay. Like that, when you extract teeth, it doesn't cause an airway problem. And there were some major, major flaws with the study, but the main thing is it didn't even determine if the people who had missing premolars had them removed for orthodontic treatment.
Okay.
Like they could have just lost them because they had perio disease or had fractures or were born without them.
Right.
They looked at nothing related to orthodontic treatment. They literally only looked at chart reviews they selected, it was like 5,584 patients in the study that they looked at patients missing premolars in 4 quadrants.
Okay.
And patients who had obstructive sleep apnea as a diagnosis in their chart.
Wow. Okay.
That was it. And they just cross-referenced them and said, oh, there's no higher incidence. But the title of the article is Evidence Supports No Relationship Between Obstructive Sleep Apnea and Premolar Extraction, an Electronic Health Records Review. So it makes it seem like that there's no relationship between pulling teeth for ortho, right?
Yeah.
And airway. Very, very poorly done article. It was Journal of Clinical Sleep Medicine in 2015. So that created a lot of confusion. And you'll hear, I tell you that because you're going to hear a lot of orthodontists, and people listening will hear a lot of orthodontists who will quote that article. Okay. And say, well, the 2015 Larson study said it doesn't make a difference. Well, those patients, there were no orthodontic measurements. They didn't look at whether the patients, as I said, had ortho treatment, how they moved teeth, nothing. So it's really, truly, truly an invalid study.
Yes.
But I have an interesting take on this that is probably different from a lot of people. I don't go around saying that extractions cause airway problems.
Okay.
And I say that because it's not like that patient walks into the surgeon's office or dentist's office, whoever's going to pull the teeth, breathing beautifully, and walks out and that night has sleep apnea or sleep disordered breathing. Meaning the physical act of removing 4 premolars isn't causing airway problems. And that's why we're never going to get a study to show that it does, because the vast, vast, vast majority of those patients are getting their teeth pulled because of crowding.
Right.
Study from McNamara and colleagues, O'Connor and Howe in 1983 in AJO, they did a study to look at, and others have done this similarly, but this was a really great study. They looked at 104 patients, 54 with severe crowding, 50 without, and they measured their teeth and their arches. And they determined that literally across the board, patients with crowding, it's because of small arches, not big teeth. So that patient's getting tooth mass removed because there's not enough room for their teeth. It's a small jaw problem. So my contention is that patient already had an airway problem.
Right.
Otherwise, at 11, 12 years old, they're not going to get tooth mass pulled for not having big enough jaws.
Right.
So that's why the data in the literature, what do they look at? They look at that patient before ortho and after ortho. And did the airway get worse? Well, if they were already narrow and constricted. Now, if you really constrict more if you had a lot of space left and you really constrict more, yes, you're going to make the airway, in theory, even worse because you're taking away tongue space. Right. But in a lot of these patients, when you let them get that crowded and you pull 4 premolars, there's not a ton of space left afterwards.
Right.
Occasionally there is, but not a lot. A lot of times there's not. So in those patients, you're not going to see a big change.
Yeah. Right. It was there already.
Right. What I want to do is look at it from the perspective of, okay, we're going to take the patients you treat with extraction and look at their airway and breathing when you're done. And we're going to take the patients I treated without, that I started early, and we're going to look at their airway and breathing when I'm done. And we're going to look at my finished cases at 14, 15 years old. And look at their airway anatomy, volume, etc. Breathing, look at their PSQs, right? And we're going to take your patients. That's the type of comparison we need.
Yeah.
And then we could start to show that it's not just about extractions causing airway problems. It's about a reactive approach to patient care, ignoring an airway problem that caused teeth to be so crowded, they had to be removed. Did I say that in a way that?
Yeah, absolutely. Okay. And the fact that it's also to, that progression, because sometimes it is just mouth breathing, and then that becomes, snoring and mouth breathing, and then that becomes sleep apnea. So, it's that progression too. So in that study, how much time passed when they did that? Yeah,
they were adults. They were all fully grown adult patients that were included in the study. So I think it was like 40 to 60-year-olds. I mean, they were old. Yeah. And that's another great point. And that's the other big problem with our profession right now is most orthodontists believe that you need a diagnosis of OSA with a sleep study, polysomnography, to even say the word sleep with a child or airway. And I have these arguments with them all the time online. Yeah. I'm like, you said it beautifully. Sleep disordered breathing is a spectrum of disease that starts with primary snoring, and OSA is end stage disease. Right. And that primary snoring, mouth breathing is the canary in the coal mine. That's what we need to be looking for in these young kids so they don't end up with this chronic obstructive airway condition for the rest of their lives and having all the associated comorbidities and medical and psychological complications of not sleeping. And that, again, you said that perfectly. I'm glad you brought that up because that's also part of that Ortho 3.0 shift. Like, stop waiting for the disease of OSA. And sleep studies in children, as far as polysomnography, AHI in children is essentially a construct. I mean, it's not, it's extrapolated from the adult data. There's a paucity of data on children's, on normative sleep in children. We don't have great data on that. You ask any sleep physician if you rely solely on a one-night PSG for a diagnosis of airway compromise in a child, and they will tell you absolutely not. A lot of them aren't checking for RERAs and arousals. I mean, I've had patients, they say got woken up at, the parents will say they woke the child up at 4:30 in the morning to stop the test. Like, the children almost always are going to have their greatest chance of having an apnea or hypopnea of either 2 successive breaths and or 10 or more seconds duration in their deepest sleep cycles, when they get deep into REM. You wake this poor kid up at 4:30. What time did he probably fall asleep with all the electrodes and staying in this, not where he typically is living? I mean, this child didn't get into deep sleep. Yeah. And then you come back that the sleep study is normal. It's right. So,
or the problem with saying it's mild, right? Like, I forget, someone said, like, you can't be mildly pregnant, right? You're pregnant or you're not pregnant. So like, to say it's mild sleep apnea, a lot of the times makes parents think like, oh, it's, it's okay. It's just mild. We'll monitor it, because that just mild alludes to like, it's not a big deal, when really, like, a lot of times I say, take a video, bring a video to your pediatrician, video them sleeping, because like I say the same thing you said, snoring is never normal. Like, like, again, sick, sure. But on a regular basis, the snoring, the amount of times I hear like, oh, the pediatrician said they'll outgrow that. And you got to dig deeper. We can't just keep falling back on the outgrowing part, because we're losing valuable time in this child's life.
Yeah. And now that we know the neurocognitive deficits that occur, and that's sound in the medical literature, hypoxia, the impacts of hypoxia. And for your audience who may not realize on the sleep study, not to kind of geek out on it, but just to be diagnosed as one incident on the AHI scale, which is what they would class, you have to have at least one apnea or hypopnea, apnea complete cessation, hypopnea partial cessation, and their scoring criteria therein. But you have to have that for 10 or more seconds duration, as I referenced before, and or 2 successive breaths. Well, they could have apneas or hypopneas of alternating breaths of 5 seconds duration, and it's never going to register on the AHI scale, the apnea hypopnea index. So this child could be having episodes of hypoxia all night long. They could be in complete sympathetic overdrive. That ties into the bedwetting, the enuresis, and all of the other things that happen, the bruxing, and not getting deep restful sleep. And they could go get a sleep study and they could come back as a 0 for their AHI And a lot of physicians will say, see, I told you the child's normal. And sadly, the orthodontists love to hear that because they're like, see, nothing I can do. This child doesn't have a sleep or an airway problem. And a lot of when I lecture nationally on this, a lot of the talks I give are in-depth discussions of what even sleep disordered breathing is and how it's more than just obstructive sleep apnea, why pediatric sleep studies are flawed. And I quote the medical literature on this. There's actually an interesting study that was done, Yoon, Jane, and Shapiro, I believe was in 2012, on something called the first night effect.
Okay.
And it was in Sleep Medicine Reviews. And they talked about the fact that for a child, even for adults, but especially children, to get reliable data, whether or not we think AHI is that valuable, but just to get a reliable read on their sleep, it should be 2 or ideally 3 successive nights in the same sleep lab.
Yeah.
And that you can essentially discard the data from the first night.
Wow.
But how many children go for one night, right? All of them. And they make that the diagnosis off of that one night. So the sleep study industry isn't standardized. Some use different criteria. There's different criteria for different ages. There's recommendations that the American Academy of Sleep Medicine has, but not every lab has to follow them. Some people, the type of sleep test you get is dependent on the insurance you have.
Wow.
That's why, right? Like we have to be better than that and realize, and just the money, not everybody can afford one. Not everybody has access to one. So we need to figure out the ways to detect the signs and symptoms of sleep disordered breathing in our patients. And we can before we rely on this somewhat frequently, very, very frequent false negatives in this test. We need to rely on our clinical skills. And that's a lot of what I teach is how to see this stuff in young kids when they present to your practice and detect these signs and symptoms of sleep disordered breathing so that we can get them the help they need.
Yeah. Wow. That's so important. And it's like, no one learns this in parenting 101 school. So it's like trying to get to the parents and educate them. Again, you mentioned about social media, and I feel as much as that can, have its negatives, it really is empowering parents to hear something, to catch something where they're like, wait a second, that sounds like my child. And, then they start going down that little rabbit hole of things. And within the last, I would say, 5 years, one of my biggest referral sources right now is coming from the parent, which was never, it was never when they first called and I see what, they said over the phone. It was never, oh, I'm referring my child, I'm concerned with mouth breathing. And now that's mixed in there just as much as the orthodontic referrals. So I love seeing that because I think, that's where the power is. It's in the moms and the dads that are going to start demanding this. I'm not going to put my child on ADHD medication when I don't believe it's ADHD and I believe that it has to do with their sleeping patterns.
Yeah.
That's going to be where it really becomes powerful, I think.
Yeah. And those medications come with tremendous side effects, addiction. I mean, I just gave a talk about a month ago up in Georgia to a big group up there. And one of the attendees, it was an interdisciplinary of all types of dental professionals, but one of the gentlemen was an orthodontist. And he came up to me afterwards and he said, I had 2 kids, both diagnosed with ADHD when they were younger. They're now adults. And one of them went through severe addiction when she was, I think he said in her late teens, early 20s, because it started with the essentially methamphetamine that they're putting these kids on when they're little for their ADHD. And he now is extremely passionate in the sleep and airway arena as an orthodontist. And he was able to detect that a lot of what it was basically they had sleep disordered breathing as children. And it's, I acknowledge that ADHD can occur in the absence of a sleep issue for sure. But there are studies that show that upwards of 50% of patients diagnosed with ADHD have sleep disordered breathing.
Crazy.
So
crazy, but makes sense, right?
Right. I mean, how do we feel? We get a couple nights where you don't get good sleep, or if you have little ones when they're young, you're way off, right? Yeah. Your temperament's off. And now think about every night of that, and you can't catch up.
Yeah.
Of course, these kids are going off the wall. It's, and I saw it all the time in my practice where they'd start. And that's actually another reason too on why orthodontists don't want to treat them is because a lot of those kids, when they first come in, 5, 6 years old, they're literally flipping in the chair. And most orthodontists, I've heard orthodontists say all the time, well, they're not ready for treatment. They're not mature enough for treatment. Well, I guess they're probably right in a way, like, but why are they like that? And then you have to really have the behavior management skills to try to start to treat them. And that's, when you're seeing 75, 100 patients a day, you really want that child back in your clinic? I'd like to say most would think in the interest of that child. At the same time, they're thinking in the interest of all the other children that's going to disrupt.
Right. Yeah.
In fairness.
Yeah. And you explain it that I always ask, how are they with their attention throughout the day, and how's their emotional regulation, and, being able to, sometimes I'll say to a parent, well, think back to when they were 18 months old, right? And they skipped their nap. What was the evening like for you, right? They were crazy.
I love that.
Oh my God, they skipped their nap. So that is ultimately what's happening when they're not getting quality sleep. And so many times the parent will say like, oh no, they're right to sleep 8 p.m. and they wake up at 7 a.m. They're getting a great quantity of sleep, but that doesn't always mean quality. And we have to explain that to parents a lot of the times.
Yeah, the tossing and turning at night, throwing the covers off, the waking up upside down in the bed, and the night sweats. And people are like, oh, when they're out, I'll hear it, like you said, they're like, oh, then they're out.
Yeah.
That doesn't mean they're getting deep, restful sleep. It's they're purely exhausted and their body shutting down, but their brain and the oxygen desaturation that they're incurring, that insult to the brain is real. And I hear all the time when I would do this, the mom I was referencing that I had on the show recently, she's like, literally, the parents say all of a sudden, a few months into treatment, like she's like not waking up like a zombie, and she actually wants to go to school. They're like, where did this child come from? She was now excited to get up in the morning and go to school. And that is my why.
Yeah.
That's why I phased out of the private practice realm and went into the full-time education realm, because somebody has to get out there on the orthodontic side and start explaining this. I was so blessed to change so many lives with this type of approach. And the orthodontists in my community, my colleagues, were like totally dismissive of it. I would offer them, I'm like, you can come to my practice and watch what I do. No, they totally shunned me for it. They didn't want any discussion. Wow. That's when I realized, because every parent was saying, why are you the only one doing this? Why is no one else doing this? And that's when I realized I had a calling to do something beyond just what I could do with my own two hands and go teach this and expose people to this, because these kids deserve it. They don't deserve to be ignored when they're not breathing well young.
Yeah. So grateful that was your calling, because it's the, selfless one, right? It's, I'm sure when you were in the clinic, you were getting a lot more of that, like, wow, this is, amazing seeing the results. And now you're here trying to, stand up to those that are maybe saying otherwise. So we appreciate that so much, because that's what we need. And, you're doing amazing things, spreading awareness and education. And as I mentioned before, I think we started the recording part of this, that I listened to you speak at the PANI conference on Long Island. And, you do such an amazing job. You're a very inspirational speaker, and you catch the audience. And I'm looking forward to seeing how much more you can do in that area, because it's so important.
I appreciate that very much. Thank you. And thank you for continuing to get this out and speak about it. And every person that listens to this that you reach is another person that the message spreads to. So I know from podcasting myself, this takes time and energy and work and preparation. And so I appreciate that you are continuing while practicing, taking the time to do this and get this message out, because it's so important. We have to keep educating people on this.
We have to, absolutely. And I hope that this episode has empowered more parents and more professionals, and even planted some seeds for those that maybe are just getting into this space of early orthodontic treatment.
Yeah, I hope so too. I really appreciate you having me on.
Yeah, thank you so much. And I look forward to maybe seeing you on Long Island soon, or at a conference soon. I really, really appreciate having you on today.
Yeah, thank you. I'll be back at PANI. Actually, Steve Lamberg is amazing. He invited me to speak again in 2026.
Oh, yeah.
So if you're there again, I'll get to see you at that. I look forward to it.
I will be there. We never miss that one.
Awesome.
It's the one we don't have to travel for. So
that's nice too. Yeah. And I love it. I get to go back to Long Island, see some friends from the old days. So it's fun for me too.
That's fun. Awesome. Well, thank you so much, Dr. DeLuke, and I look forward to connecting in the future. Thank you for joining us on this episode of Talk the Talk.
We hope it was enjoyable and educational and further supports you both personally and professionally.
For more information, please check out our Myo and Myo Minute podcast, as well as our other episodes of Talk the Talk. And don't forget to check out our tongue training appliance, Spot Pal, to help with tongue thrusting, thumb sucking, snoring, TMJ, mouth breathing, and so much more. Visit thespotpal.com.